when you are taking the history, most important thing, remember the structure. So what are the structure you should follow in any history whatsoever?
Start with like an introduction and then
So introduction, very
presenting
important.
complaint.
Introduction and making a rapport, that is very important. And if you don't do that, you won't be able to get much history, which she did reasonably well. And she sat in the same level with a distance. So these all counts. Okay. So what next? Then introduce yourself. Usual thing. Make sure that you have identified the patient. And so next, what are the structure you have to do?
Presenting complaint
Presenting complaint.
and then history of presenting complaint.
History of presenting complaint.
Past medical history.
Past medical history.
Drugs. or-
Drug history.
Yeah, and then family history.
Family history.
And social history.
Don't forget something else.
Surgical history.
No, allergy.
Allergies, yeah.
Allergy and the social history. Obviously, then you have to, what else do you need to take as a structure? Each and every time, whenever you take any history, do not you should do a system review, provided you have time. What else? Because remember, in exam, you will not get more than 7 minutes to complete a history.
Summary or something.
So that's very important. So when you take a history, summarize it back to the patient. So what I would have told that patient is, I have understood that you woke up and you had a sudden onset while you were driving. You felt that you didn't see a car and hit the car, and then you realize your left arm and leg was not working properly, and that's what brought you to hospital. You said that you had a bit of headache prior to that, and then when you summarize, you had you suffer from high blood pressure and you smoked for a considerable period of time, and you tell the exact amount and etc. But you don't, so then you include what are the important negative history which is not there. For example, he didn't have history of diabetes, he never had previous stroke, so this you include. And presently you are having rehab and things are getting better, but you want to go home as quickly as possible. So then what is the last thing that's the summary. So is there, and then you finish by open question, is there anything else you want to ask? Okay, but before that you should do another one, eyes, never forget. So idea, concern and expectation. So what is the idea of the patient? So he clearly have an idea that he had a stroke because he told you, and he told that he had a bleed in the brain. So what is his concern now? Getting home. So what is his concern is not getting home, that is the expectation. Getting home as quickly as possible and go back to his normal life. What is his concern? That his concern is he got upset. So what is his concern? That he is concerned that he might not be able to go back to his normal life after he go back home, isn't it? So he told that he is a driver by occupation. So he is concerned that probably he won't be able to drive anymore, at least in near future, and that would affect his profession. So that's his concern. So whenever you are taking a history, you have to capture all these things, because that will, no matter whether it's a neurological history, a cardiac history or a respiratory history, any system, this structure you have to capture. And if you capture this structure, most of the time you will pass easily. Okay. So next come specifically about the neurological history. Okay. So when you are taking the neurological history, what are the common symptoms you should think of?
Headache.
Do it in a more systematic way. So when I take history, I just follow the routine what I do in examination. So when I do examination, what are the things I am looking for? Is there any higher mental function abnormality? Okay. Is there any cranial nerve abnormality? Is there any problem with speech? Is there any problem with motor movement or motor? Is there any motor abnormality? Is there any sensory abnormality? Is there any abnormality related to cerebellum? Specifically, if there is any problem with coordination, problem with balance and posture. So that would give me a clue whether there is a cerebellar involvement. Is there any problem with gait, walking? Okay. Is there any problem with headache, seizures? So these are the associated symptoms. Other autonomic symptoms, sometimes it's very common with neurological patient. So they get autonomic symptom. What are the autonomic symptom you can think of? especially in migraine. Sometimes in seizures, you can get autonomic symptoms like nausea, vomiting, feeling generally unwell, sweaty. Okay, so these are the features you can sometimes get in patients. What else? Any other thing in neurological history? Have we
Vision.
covered anything? Vision will be all covered in the cranial nerve abnormality, and we will come to that. Okay. So this covers most of the thing as when it comes to, and whether they have lost consciousness. Obviously, higher mental function would capture that as well. Okay. Now, in terms of higher mental function abnormality, when you are taking the history, if you talk to a patient, you will have an idea. Is this patient confused? Is this patient delirious? So all these you will have an idea. So specifically when you are taking a normal history, not when you are taking higher mental function abnormal, when you are checking, that is different. But in normal history, you don't check anything as such. But as you are talking to the patient, you will have an idea. Is this patient confused? Was Michael confused, do you think? I don't know. Like he probably might be, I don't think he was confused, to be honest. Like he was quite with it. Okay. So you know from just talking, I didn't check anything. So the next most important thing when you are taking the history, for example, let's start with the motor abnormality. Okay. So when somebody has got weakness of the limbs, what are the questions you are going to ask?
Which side?
Before which side? What? How was the onset? You have got a mnemonics about any weakness. How do you take? No, like for neurology, I know you have got a Voldemort, Voldemort, but I think this is a better way to cover because you won't miss anything. The way I'll tell you, if you follow this, you won't miss any neurological history. So if you come to motor, how was the onset? Is it important to know how was the onset and why?
If it's acute or chronic.
Okay. So whether it's acute, first of all, acute or chronic. Okay. Acute, there are certain conditions. Chronic, these are more degenerative condition, etc. Okay. So if it is acute, then you think of, is it sudden like within minutes to seconds to minutes, or is it minutes to hours? So if it's seconds to minute, which probably in his case, because he could drive and then suddenly something happened where he bumped the car, isn't it? So if that's the case, what would you think? What is the commonest cause where the onset is sudden in seconds to minutes?
Stroke.
So that is a neurovascular event or stroke. But if it is within minutes to hours, what would you think? And especially if the evolution in stroke, the other important thing, when it happens suddenly and all in one go. Okay, so for example, if the limb is weak, you expect that at outset the deficit is usually there. There are exceptions, but in general, okay, at outset you will see the weakness. Okay, but in which condition the motor deficit can appear within minutes to hours rather than seconds to minutes?
That'd be like a bleed.
No, bleed is again a neurovascular event that happens suddenly. Seizures, obviously the history would be slightly different.
Carotid dissection.
No, that's again part of the no migraine. Okay, hemiplegic migraine, where you get the symptom within minutes to hour. And the other important thing, yeah.
I was just checking you were still here.
Okay. We will start the family. There is a family meeting. I think at around 12. Yeah.
12. Okay, 12.
No, 12. Quarter to 12 or 12ish. Okay.
Fine. Okay. Just let me know when you want to see 17.
Yeah. Okay. So if this is if it is a migraine, how does it evolve? Like in stroke, it comes like if it is weak, it will be sudden. Whereas in migraine, they will say that it's like marching. First of all, they won't be able to move their finger usually, then the wrist, then the elbow, and then they cannot move it at all. Okay, so that's the difference. What else?
What's the question, sorry?
So when you are taking the motor history, what are the things you are looking for? So what we have said, how is the onset? Okay, how is the progression? That is very important. What next? what is the pattern of the motor involvement? Is it on one side of the body, like right arm, right leg, or in his case, left arm and left leg? Or is it both the legs? Or is it all the four limbs? Or is it one limb? Is it important to know that? Why is it important to know? So, for example, if it is both the legs only, no arm, where the problem is, you think? Could be.
The homunculi where it's
No,
all linked.
remember this is I'm talking about general neurological history. Don't have to.
Posterior.
So it's more commonly it would be the spine. Okay, you can get bilateral anterior circulation involvement where you can get only both the legs, because if you think of the homunculus, the legs are supplied by the anterior cerebral artery. So if you have there is lesion where if you you can get in very rare circumstances where one of the anterior cerebral artery is blocked, but because it supplies both the sides of the brain, you can get bilateral weakness of the leg. But these are not common, but it is possible. But in general, if it is a bilateral weakness of the leg, you would think that the problem is in the spine. If it is all the four limbs, but there is nothing in the face, where would you think the problem is?
C-spine.
So cervical spine. Okay. Whereas if it is one side of the body, including the face, where would the problem be?
The other side.
Other side in the brain, either in the thalamus level or higher up in the cortical level. So having the idea which part is affected, that gives you a clue where the problem is. Okay, helps in localization. What else in motor? Which can give you a clue?
Severity.
So severity is important, like how severe is the involvement and how is the progression, how is it progressing. Apart from that, even in the limb, is it proximal, distal, or both? So for example, if you have to take a history of proximal weakness of the leg, what history would you get from the patient?
So like they're fine to move their leg, but they can't lift their hip up. Like,
So what common day-to-day activity they will struggle to perform?
Walking.
Walking can happen both with proximal and distal. So we cannot say walking.
Driving.
No.
You're going up and down.
Hmm. So getting up from the sitting position, for example, getting up from the commode, okay, they would struggle if only the proximal muscle is weak. If there is a weakness, I'll upload it, so don't worry. We don't have to write. So if there is a weakness around the ankle, what would be the common symptom?
A limb.
Yeah,
It has
on
to
the
be.
no, just the ankle is weak.
Tripping over, rolling.
dragging your foot.
Dragging the foot. Okay, foot drop. We get the dragging of the foot. If the patient say that I've noticed when I'm walking, I'm dragging the foot, immediately you think of what will happen if there is weakness of the small muscles of the foot. This is a difficult question.
Inability to like lift up.
That's the ankle joint. If the small muscles of the foot are weak,
Do you end up with like balance problems?
it's not mine.
With like walk on heel or something.
No. Anybody? Use your common sense. Where you would give a history, a very important difficulty in keeping a slippers on. Okay, not shoes or boots, slippers. Why is that?
Because things slide up. You can't like.
Yeah, so when you are putting the slippers on and walking, you contract your small muscles to keep it in place while you are walking. And if you cannot, if you haven't got that power, you won't be able to keep it in place. Your slippers will go on. So if somebody say that I cannot keep the slippers on, I don't understand why that is the case. Always think if there is a small muscles of the foot involvement. In stroke, what is the common type of involvement?
Both sides. One side. Both.
One side, both limb. What else? Is it proximal, distal, or both? So it's both, but because usually in pyramidal tract you get the distal more affected than proximal. Usually, it can be other ways as well, depending on but usually that is the pattern of involvement. Is that clear? Okay. So these are the important thing you take in the motors. So in case of our patient, he had weakness of both left arm and leg. It was both proximal and distal, but more on the distal part. Okay. But his symptoms has improved since his admission. Okay, so that's one. So motor. Next is sensory. So what are the sensory modalities you know of?
Pain,
So pain,
temperature,
temperature,
fine touch,
fine touch, crude touch. What else?
Vibration.
perception.
Proprioception,
Vibration.
vibration. Anything else? Proprioception, joint position sense. Oh, okay, so that's you said that. So that's the. So what are the pathways for all this sensation?
Dorsal columns.
So dorsal column is responsible for
Crude touch, fine touch.
fine touch. What else? Proprioception. What else?
Vibration.
Vibration. Okay. So these are the common modalities which are carried by the dorsal column. What about the spinothalamic tract? What do they carry?
Pain.
So pain, temperature, crude touch. So these are the common modalities which are carried by the spinothalamic tract. What else? Is there any other sensory tract? Spinocerebellar. Very good. And what does it carry? It carries proprioception information, unconscious proprioception information to cerebellum. So there is one. Okay. Now, who is going to draw the dorsal column?
Vibration, fine touch.
Pri, why don't you draw the dorsal column on that?
Someone can chip in.
Sure, I help you.
It's called the medial meniscus pathway, which means that it exits in the medial meniscus. That's what I know.
Okay, just take that. Okay, when once he's drawing, if you can show that side. Get some tissue and just,
Do I just
So you got some sort of sensory information coming.
So sensory information coming. So we are talking about the dorsal column, which can be fine touch. It could be vibration or proprioception. So that information is come.
Yeah.
So what does it do then?
The first order neuron.
So where does the first order neuron go through? This is the sensory route
gotcha.
where it will come out. Okay.
Yeah.
So there is a body here.
Mhm.
Okay. The question is, does it decussate? Does it relay here or not? If it is dorsal column.
It doesn't decussate. It doesn't decussate, but
No. Does it relay in the dorsal root?
synapse.
Yes.
Synapse?
Yes.
Yes or no?
Yes.
The answer is no.
No.
Okay. So it doesn't. Okay. It doesn't relay here. It goes on
Yeah.
and goes where?
to the medulla.
To the medulla.
Yeah.
Okay.
Second order.
Does it relay in medulla?
Yes.
Yes. And then decussate.
So which nucleus in, don't jump, which nucleus in medulla does it relay?
if it's below T6, then it's green.
Nucleus gracilis
Gracilis
and
and
nucleus
cuneatus.
cuneatus.
Yes.
Okay.
Yes.
So for example, nucleus, we have said that this is the lower limb.
Yeah.
So nucleus gracilis. So what happened? It relays
Yeah.
there. So what happened next?
Second order neuron.
Second order neuron, what does it do?
It just decussates.
So it cross the midline, decussates,
Mhm.
and then go up along the medulla, pons, and midbrain.
Yeah.
And then where does it relay? Does it relay?
Yeah.
In the thalamus. it will-
So it relays in the thalamus. Which nucleus of thalamus does it relay?
Ventral VPN.
Ventro, postero, lateral
Lateral,
nucleus of
Medial.
ventroposterolateral. Okay. So from there, so now while it is going through the brainstem, what tract is it? What lemniscus is it called?
Medial lemniscus.
Medial lemniscus. So we have discussed about 4M and 4S.
Mm-hmm.
So this will be medially and relay in the ventroposterolateral nucleus of the thalamus. And from there, what happens?
It goes to the sensory.
So it goes to the parietal lobe. Okay. Is that clear? Okay.
Do you want to label them?
No, that's fine. So that's the dorsal pathway. What about the ventral pathway or the spinothalamic tract?
No idea that one.
Anybody?
So that's synapses within the spinal cord.
So that synapses within the spinal cord.
Crosses over the ventral white commissure, so the ventral aspect.
So as soon as it synapse, what happens? The rule is once they synapse, they usually cross the midline. Okay. Now there is after they synapse here, they can go up or down, but that's not important. After they synapse, they cross the midline. Okay. They cross the midline
Yeah.
and then they go up. They go up along the spinal cord as spinothalamic tract in the spinal cord.
Yeah.
Okay. When they reach the thalamus, brainstem, they go as spinal lemniscus. And spinal lemniscus is medially or laterally in the brainstem?
Lateral 4S.
Lateral, 4S. So it goes laterally, goes to which nucleus?
APM.
Same nucleus, ventroposterolateral nucleus. Okay. And then it goes to the parietal lobe. But when it comes to pain, it is much more complicated. So how is it more complicated? Now I am simplifying it. Pain has got two pathways. One is the fast and another is the slow. Okay. So depending on whether it's A delta or C fiber, but we are just simplifying it. So the pain in general, it travels to the thalamus, but it has got other functions as well. So what happens if somebody get painful stimulus to their general arousal state? Do they get, if you are sleepy, if somebody give you a painful stimulus, what will happen to you?
Wake up.
Wake up. Why is that?
Sympathetic system.
So when these fibers are going through the brainstem, they supply the reticular activating system. Okay. Now, when they go to what else do they supply?
Is it the
The spinothalamic, right?
Yes.
amygdala?
So they travel to amygdala. What else? So from there, because there are two pathways, we are making it simplified because it depending on A delta and C fiber, but they can go to amygdala. Where else?
Hippocampus.
So amygdala, hippocampus. What else? What happens to your emotion if you get a pain?
Cry.
So you change your emotion. So where does the fiber needs to go? They go to the cingulate gyrus. Okay, which is medially like this. They go to the insular cortex, which is the higher center for autonomic nervous system. So that's why if you have pain, what happened to the pulse rate? It can go up because the autonomic nervous system is affected. And remember, there are lots of descending pathway as well for pain. When they are going through the brainstem, they can stimulate some descending pathway, which can modulate how you feel the pain as well. Okay, for example, periaqueductal gray matter. So they can come and inhibit the fiber. So where there is a relay, they can do that. What is gate theory? Anybody?
Pain gate theory. So it's where the faster fibers are inhibiting the slower fibers or something.
So when you activate the heat.
So this is the gate theory which I sometimes use when I'm doing, for example, an aesthetic one. So the idea is when these dorsal column fibers are going, okay, not only they don't relay in the spinal cord, okay, but when they are going, they send some fiber to the inhibitory neuron, which is supplying this synapse here. So what happens? So if you are, for example, if you are going to puncture the skin, which is going to stimulate the pain fiber, but at the same time, if you put a vibrator by the side, so what is it doing? So while the vibration is going there, it is sending information to the synapse to innervate. So that is pretty essentially causing the gate to close, so that even if the information comes for the pain, it won't be able to transmit, or even if it transmit, it will be much lower. So that's the principle what we use commonly as well. Like, you know, you put a vibrator and then you do a puncture. Even for venipuncture, if you do that, you will feel that they will feel less pain, because the vibration is going to the pathway, it is inhibiting at the level of the spinal cord. And that's why the pain sensation will be much less. Okay, so that's the, but pain is quite more complicated. As we have seen, it's not only just going there, there is all two-way pathway. Now, why do you think all these sensory fiber are relaying in thalamus? Why can't they go? They have traveled so far. Okay, why do they need to relay in thalamus? Why can't they go directly to the cortex?
The thalamus directs the projections into
What else?
Interpretation.
So what is interesting about thalamus? Thalamus is a beautiful structure. What is interesting about thalamus? It sends 1/10 of the fiber from it to the cortex, then it receives. So thalamus is actually receiving lots of fiber, 10 times more than what it is sending. What does it tell you?
It's a filter.
It is a filter. So regulator. So it is only sending the information which are important. Okay. So that's why I keep on telling you, you only see things which your mind knows. So if your mind doesn't know, you won't see the things, because it's all filtering in thalamus. It's like a gateway. It's filter. It's not just relay. It's filtering and sending the information which are more appropriate for you, which are more relevant to you. Otherwise, you will have all the information. Your brain won't be able to handle what is needed. So that's the important role of the thalamus here. So apart from that, what other pathway? We have got the dorsal and the ventral cerebellar pathway, which, remember, what do they carry? They carry the proprioceptive information. Like the dorsal column, they carry the proprioceptive information. And the key thing is, if it is either ventral or dorsal, however complicated it is, dorsal is very clear. It goes directly to the cerebellum. Ventral is bit more, but ultimately it will end up on the same side. Unlike the other fiber, which is ending up in the opposite side in the cortex, the cerebellar, spinocerebellar tract, they eventually end up on the same side of the where the information is coming. So the right side receive the right information, the left side receive the left information, unlike the cortex. Is that clear? So when you are taking the history of sensory abnormality, what are the things you are looking for? What are the questions you are going to ask?
Yeah, any pain?
So whether there is any, so remember, when it comes to the sensory abnormality, you in stroke, what type of sensory abnormality you normally get? Is it a positive sensory abnormality or a negative sensory abnormality? So what do you mean by negative? That's right. The answer is
can't feel.
yeah. So every sensation is lost. Okay. Whereas in some other situation you can get positive symptom.
Yeah.
So for example, migraine is one of the typical where you get positive sensation. Okay, be it visual, be it sensory, be it auditory, it's all positive. Whereas in stroke, you won't be able to hear, you won't be able to see. So all are usually negative. Okay. Now, when it comes to the sensation, again, what is the onset? If something is happening over weeks, months, then obviously you suspect something more degenerative. Whereas if it has suddenly, like in stroke, it would be quite sudden. Okay. If it is a positive or negative sensory impairment, so if it is a positive, that is more in favor of migraine, whereas or seizures. Whereas if it is negative, it is more in favor of stroke or cerebrovascular or neurovascular disease. Okay. What else? What is the area of distribution? Is it important of the sensory impairment?
Yes.
If both the legs are affected, you would suspect that it is in the spinal cord. If only the extremities are affected, like in the glove and stocking area, what would you suspect? Peripheral neuropathy. if the sensory loss is in the distribution of glove and stocking area, so where you wear the gloves and stocking, if that is the characteristic feature of peripheral neuropathy, okay. What else? So if there is loss of sensation on one side of the body, where could be the lesion?
The brain.
Brain, which part of the brain?
The
Cortex.
So it could be in the cortex, it could be in the thalamus. Okay. What is the difference? What happens if you have got cortical involvement? What extra you can lose? So in other words, what are the important cortical sensation?
Movement.
No, movement, not sensation. How can it? Yeah, there is a link between movement, but not that I am looking for. What are the cortical sensory modalities? What is stereognosis? What is 2-point discrimination? And what is graphesthesia? What is graphesthesia?
Drawing.
Drawing what? So for example, give me your hand and close your eyes. Okay, keep your palm here, take everything. So I will draw a letter. You have to say which letter is that. Okay.
I can see it.
But it's probably you would be able to do that.
I'm concerned.
Okay, so that's called graphesthesia. Okay, so if they cannot, you just check. I'm sure his modalities are okay. The next is 2-point discrimination. Okay, so what is that? So close your eyes. Okay, how many finger am I touching? One. How many finger am I touching?
2.
You're cheating.
I got
Okay.
2.
Okay, how many finger am I touching?
1.
How many finger am I touching?
1.
Am I? So this is normal. Okay, remember, because different part has got, but this is a cortical sensory where you analyze. Okay, this is cortical sensory. This is called 2-point discrimination. And the next one, keep your eyes closed. Okay, I'm giving you, but don't take it away. Okay, so what is this coin?
Mine.
Yes, that's right. So that is what is this called? Stereognosis. Okay, so you feel it. So it is a higher cortical sensation. It is not processed in thalamus. It is processed in this parietal lobe to find out not only what is the texture, what is the shape, and from your previous experience you can tell that this is a pound coin. But if their new pound coin has come in the market, you are not aware, you won't be able to tell because you haven't learnt it. Okay, so that's the higher cortical function.
So if you lose sensation in the brain, in the cortex,
You will struggle with that.
Okay.
So what about thalamus then?
Like thalamus, obviously you will if the information is if it is blocked in thalamus, it won't go into the in the parietal lobe anyway. Okay, but if it is specifically there, then you can say that this parietal lobe is definitely affected.
So because thalamus comes before cortex,
Yeah.
and obviously that information that you're feeling for a pound coin or something, that information has to travel up to the
No,
thalamus. and then-
in that case, your sensory abnormality will already be there. Okay, but you have to find out other corroborative things to add to where is the lesion.
Oh, okay.
Okay, so this is one of the aid in different thing to add. It's not the only thing, but this is, if you know, you can find out whether this is in the thalamus. There are other ways like on top of this which will help you to find out whether it is in the in thalamus. If it is affected, usually the sensory impairment will be quite dense. Okay, because it's a very small nucleus. If it is affected, everything will go. Whereas if it in the parietal cortex, it has to affect a large area. So you expect, if it is a